So good evening, and thank you very much for joining our webinar on blocked noses and blocked ears. My name is Louise and I'm your host. Our expert presenter this evening is consultant ENT surgeon Henry Sharp, you see on the screen. Today's presentation will be followed by a Q&A session. You can ask questions throughout the presentation. You do this by the Q&A icon at the bottom of your screen. When you ask questions, you can do so with providing your name or anonymously, so it's up to you. And just to let you know that this session is being recorded. At the end of the session, we will put a phone number up on the screen, and my colleague Paul Farrow will be at the end of the line to answer any questions about consultations. That number is also available Monday to Friday, 9 till 5. Yeah, I think that's everything. So I will now hand over to Henry Sharp. Thank you.
Thank you very much, Louise. I'd just like to echo her welcome to you all, and thank you very much for joining us. I hope you've got a glass of something pleasant or perhaps a cup of tea or coffee. The idea is just to talk to you a little bit about what I do most of the time, which is deal with problems, particularly in the nose, but the ear as well, but also to explain to you how these can have a knock-on effect into problems in the throat as well. So cover the basics really of ENT for you in a talk for about 20 minutes or so, and then give you the opportunity, I hope, to answer as many questions, to ask as many questions as you'd like. So as far as Benenden goes, I'm a part of a team of 6 ENT surgeons who work here. We were appointed to Benenden in 2013. On a personal note, I was appointed in the NHS into private practice in 2004, but Benenden is a part of my practice that I really enjoy. Moving swiftly onwards, just to show you really a schematic diagram, which is, apart from being a pretty picture, really sort of shows the interconnection between the ear, the nose and the throat, and it's sort of me in the middle between the different bits, but it is a fairly accurate representation of how the ears, the nose and the throat is connected, and clearly symptoms in one part of that part of ENT can reflect in another, and I think hopefully you'll realize that as we go through the talk. So unfortunately at the moment, as we all know, GPs are under an awful lot of pressure. They're absolutely snowed under. COVID has not helped that, and they really are under a huge amount of stress, and I'm well aware that a lot of patients say to me how difficult it is to access their GP at the moment, and that's a problem that we feel in ENT that reflects, unfortunately, in people's experience of treatment of their ENT conditions. The other problem is that GPs do tend to see a lot of people perhaps who maybe shouldn't really be going to the GP in the first place, and this was an interesting little article that I found in the Daily Telegraph a while back before COVID. So clearly it must be true if it was in the Telegraph, but 1 in 5 GP appointments are said to be unnecessary. Now you may agree that dandruff may be unnecessary to go and see your GP about, but it also classed in that group of ailments a blocked nose. And actually, I wouldn't say that's actually trivial at all, because as we all know, having a blocked nose and having a cold is actually extremely unpleasant. And having that every day of your life, as a number of you out there will know, really does impact on your quality of life. And just if you look at the last few lines of that article, you know, there were several thousand with dandruff, several thousand in travel sickness, but 5.2 million patients with blocked noses. Now that's a 1/12 of the population has a problem with a blocked nose. So I think that's not trivial at all, and is clearly indicating what an issue it is for the population at large. So the key here at Benenden is diagnosis. You know, a lot of the patients I see here are struggling to get a diagnosis through their GP, either because they can't access them because they're too busy, or actually they don't have the equipment to hand in a GP's practice. ENT is quite a niche specialty. You need microscopes, you need endoscopes, and also you need ENT training, to be honest, to actually be able to diagnose people accurately and swiftly. And that's something that the GPs may struggle with sometimes. So we really want to offer you here at Benenden an excellent diagnostic service as much as anything, and potentially treatment as a result of that. So let's just talk a little bit about, without going into too much sort of medical detail, but you may know about your sinuses, Oops. So let's just talk a little bit about the anatomy of that. So the sinuses basically are paired structures. They're air-filled cavities in your skull, and you have several pairs of them. There are the maxillary sinuses in your cheeks here. There are the frontal sinuses in your forehead, and then there are the ethmoid sinuses, which is a little sort of honeycomb structure between your eyes here. As far as your nose is concerned, you have a nasal septum, a partition between the two sides, and you have three pairs of paired turbinates, which are sort of projections from the side wall of your nose. And you'll see those in a minute when I show you a little video, but they are little projections inside your nose that may have an effect on the nasal passage and block the nose potentially. So these are things that you'll see in a minute. Then also you'll see the tear duct comes into the nose. The tear passage, the lacrimal system comes into the nose. And at the back, which you can't see, the eustachian tube comes into your nose, which is the tube that drains from your middle ear into your nose and allows pressure changes in your middle ear. So let's have a little look around inside the nose. A sort of a caution here, if people are a bit squeamish, this is not any bloody, horrible sort of appearance, but just looks, it may be of interest to you to look what it's like inside your nose and to show you what some of that anatomy is like. So look away if you're a bit squeamish, but it's not going to be that bad, I promise you. So here we are going into the nose with an endoscope. All right, so here we have the inferior turbinates, which, as you can see, is quite a large structure. There's the middle turbinate. They do fill up quite a lot of the nasal cavity. Here's the nasal septum. As we go towards the back of the nose, there is a mild, in this patient, little deviation of the nasal septum there, which is slightly narrowing the nose on this left side. If we go towards the back of the nose, you will see here where the adenoids would be in a child, and there is the eustachian tube opening. So you can see why children get glue ear if the adenoids are enlarged there, which blocks the eustachian tube opening at the back there, and they get glue ear. But it happens in adults as well. So that's a little view inside the nose, the inferior turbinate there, which we'll come back to later as far as treatments go. So there you have a fairly normal appearance of the nose from the inside. Now, the opening gambit when I see patients who come to see me is I say, well, what can I do to help you? And they say, I've got sinus, doctor, or they say, I've got sinusitis. Now, that, in my experience, can mean a number of things. It can mean any of these symptoms that that I've written down here, because these are the symptoms really that you may be describing when you think you've got sinus or sinusitis. So sinusitis to me generally means you've got facial pain or headaches. Those sinuses that I showed you earlier get blocked, and so you get pressure pain in your cheeks, in your forehead, because of the problems in your sinuses. So facial pain or headaches is really what I describe as sinusitis. But you may also get discharge from the nose, which may come from the front or down the back, which people often describe as postnasal drip or catarrh. But other people may get problems having to blow their nose all the time. The other symptom people may describe is of a blocked nose. And if you can't breathe through your nose, this may have a number of knock-on effects in your daily life, such as snoring. Your sleep pattern is disturbed because you can't breathe. You breathe through your mouth, so you get a sore throat and you get a hoarse voice. Hence the knock-on effect into other parts of the E, the N, and the T, which I described earlier. Your sense of smell may deteriorate, which has come particularly into focus with COVID, but happens a lot in other people with problems with their nose. You may have a sneezing or itchy nose, which may specifically suggest allergy. You may have nosebleeds. And if your eustachian tube at the back there is blocked, you may get blocked ears and muffled hearing. And if your tear duct is blocked, you may get watery or itchy eye. So a lot of knock-on effects from problems in your nose. But any of those symptoms may be something that you're experiencing at the moment. So as we came back, as I said earlier, diagnosis is key here. We have here at Benenden special endoscopes, and here I am demonstrating on this patient endoscopy of the nose, which is carried out in outpatients. No anesthetic is necessary. This patient's sitting there, he's quite happy. He doesn't look particularly anxious or in pain, because he isn't. It's very easy to do. It takes about 10 seconds. It gives me a very good view on the left there of the internal aspects of the nose, which you saw earlier when I showed you. And then on the right picture, those observant of you will see the larynx. So we can see all the way down, which is the voice box. We can see all the way down through the nose to look at the nose, the back of the nose, and also down towards the larynx there. So we get a full view of the nose and the throat with that very simple procedure, which we can do in outpatients for you. We may organize some further tests, in particular that these tests, a CT scan, a special diagnostic X-ray may be necessary, and also some allergy tests. If you do have some symptoms suggestive of allergy, like sneezing or itching of the nose or itching of the eyes, running of the eyes, that does suggest allergy, and we can do some blood tests for you to fully diagnose that and to see exactly what it is you're allergic to. The RAST blood tests I refer to there, we can do to lots of different potential allergens and tell you exactly what it is you're allergic to. So these are tests that we may arrange for you in your outpatient visit. So what can cause these nasal symptoms? Well, in general, it's one of two things, or a combination of them actually, which is not unusual. Problems with the nasal lining, you may have heard of rhinitis or rhinosinusitis, which means basically an inflammation of the nasal lining, and also problems with the nasal structure. And here I particularly mean the nasal septum may be deviated, and that's probably an operation to correct the nasal septum is probably the most common operation I do. So chronic rhinitis or rhinosinusitis, this is what I mean when I mean inflammation or swelling of the lining of the nose. When we say it's chronic, we don't mean it's really bad, which some people think chronic means it's really bad. It actually means it's long standing. So chronic rhinosinusitis means you've got symptoms for more than 3 months generally. And you can describe it or diagnose it as being allergic or non-allergic. And that's really done as much as anything on the history, what you tell us your symptoms are. So allergic problems, I mean, most people will be familiar with hay fever. You get a watery discharge from your nose, you get sneezing episodes, your nose itches, it's uncomfortable, and you may well get symptoms with your eyes as well. And you may also have an association with asthma or eczema, which is termed atopy, because allergic rhinitis is very common with those other conditions. However, other people may describe a mucky, green, horrible, yellow, nasty discharge from the nose and more problems with facial pressure and pain. And that suggests to me more of a non-allergic type problem, a chronic infective problem inside your sinuses rather than allergy. So we can tell quite a lot of the likely cause of your problems just by asking you a thorough and decent history from you. How can that be treated? Well, I would emphasize to you, and this is what's, I would try and emphasize to you about coming to Benenden, is early diagnosis. It's really important to get diagnosed early with these situations, because if you don't, then it's likely to get worse, all right? And it sounds obvious, but it is. And the earlier you get diagnosed, the less likely you are to need surgery. Because most cases of rhinosinusitis, once they're diagnosed, are treatable medically without the need for surgery, with advice, various nasal drops or sprays, targeted antibiotics, and treatment for your allergy if necessary. If, however, it's left untreated, you may get more inflammation inside your nose and eventually nasal polyps, which are a sign of long-standing inflammation which has been not adequately treated in your nose. And also, actually, there's good evidence that having problems in your nose makes your other asthma and chest symptoms worse. And you get what's called the allergic march. In other words, your symptoms are marching along without being treated properly. And many people who have asthma and problems with their nose will know what I mean. If one is bad, the other tends to be bad as well. So it is, particularly if you're asthmatic, important to get treated properly with regards to your nose. It's often forgotten problems with your nose. Asthma is thought of as being very serious and everyone takes it very seriously. But the problems with your nose are, equally serious in some ways. So here's again, maybe a little bit more less for the squeamish than before, but here is a nasal polyp inside the nose. So this is a sign of long-standing sinusitis that's been allowed to progress to a point where these polyps are formed. So this sort of grey, gristly, nasty structure is a nasal polyp. It's entirely benign, but when it gets to this point, surgery is going to be required. You're not going to treat that medically, and I'll show you how I do treat it, which is a little debrider device. It's a bit like those of you of a certain age will remember Pac-Man. Well, this is my version of Pac-Man, which is a little debrider, and it removes the polyps very quickly and easily, minimal blood, and this is in real time. This is as I do it. So it really doesn't take very long for my little Pac-Man device to remove these polyps and for instantly your nose to be very much better. So this is what I do. Again, probably the second most common operation I do is this one. To remove all these polyps, one has to be a little bit careful, because just to the right of the screen is your eye, and just to the top of the screen is your brain. So you have to be a little bit careful about where you debride, but obviously within reason, with these delicate little devices and under direct vision like this, it's a very safe procedure. So that is surgery when you get to the stage of having nasal polyps, called functional endoscopic sinus surgery. What can go wrong? What can happen with the structure of your nose? As I mentioned earlier, well, you can have a twisted nasal septum, which is a partition between your two nostrils. And this can be deviated particularly to one side or the other. And it may be very obvious. You'll tell me my right side of my nose is blocked or my left side of my nose is blocked, which side it's bent to. But obviously, sometimes it's not so obvious until I look in your nose with my little endoscope. It's important to think, well, you'll think to yourself, I haven't got a bend in my nose on the outside, so I can't have a bend on the inside. But actually, that's not the case. And it's actually more common for people to have a straight nose on the outside and a bent nose on the inside than to have both being bent at the same time. So just because you've got a straight nose on the inside does not mean you haven't got a bent septum. It's something worth thinking about. And the treatment for that is a relatively straightforward operation called a septoplasty, which takes about 40 minutes under a general anesthetic as a day case. And that's very easily remedied once diagnosed. The other thing that can cause a problem is hypertrophy or swelling of those inferior turbinates that I showed you earlier. Now, that, as you can see, they're really quite large and they do fill up quite a lot of the nasal airway. So if they get particularly swollen with severe rhinitis that I mentioned earlier that doesn't respond to medical treatments, they may need surgically reducing in size. And that's an operation that we term turbinoplasty. So the inferior turbinate is reshaped. The bone that actually is in it, it's a bit like filleting a bit of beef. The bone is filleted out and the actual lining of the turbinate is reshaped to give you far more room inside your nose. Very successful operation for improving the nasal airway. So here's an example of a patient that's had a combination of things. Has had a bent partition, a bent septum, and a nasal polyp. So just to orientate you, on the left here, this is a CT scan of the sinuses. So we've taken a picture of your face. Here's the top of the head going over there, which we've cut off. Here's the mouth down here, which we've cut off. Here are the eyes, and here's the brain. So in the middle here are the sinuses. So here is the right, this is the right side, and this is the left side. So the patient is looking out of the screen at us. Here is the right maxillary sinus, which I mentioned earlier, which is full of black, which is air, which is what you want. Here is the left maxillary sinus, which is full of gray, which is polyp. All right, so that's a big polyp coming out of the maxillary sinus, poking into the nose here. In addition to that, you will see that the nasal septum here is bent. All right, instead of being straight down the middle as it should be, it goes up and then it curves with this big spony sort of spike here. So a big sort of curve over to the left side. So you've got a bent partition, a bent septum, and a large polyp blocking completely the left side of the nose. So we do a combination here of septoplasty and functional endoscopic sinus surgery. And this is the post-operative result on this side. You'll see now the septum is nice and straight down the middle here, and the polyp has gone, and a nice opening from the maxillary sinus here into the nose. All the gray stuff, which was here, has now completely gone, and these sinuses have been opened up. These are the ethmoid sinuses here. But the main thing is this big polyp in the maxillary sinus is completely gone. So that shows you the radiological results of the procedures that I mentioned earlier. So moving onwards, let's just talk a little bit about the ear, which again is something that we do a lot of treatments and diagnosis for you here at Benenden. The anatomy of the ear generally and the problems you will experience with it can be divided into 3 sections. So the outer ear canal, your outer ear, of course, is actually termed a pinna. You then have the ear canal, which goes down to your eardrum, and those 3 structures are generally termed as the outer ear. Then there is the middle ear, which is an airtight little box demonstrated on the picture here, which has 3 little what's called ossicles or bones in the middle ear: the hammer, the anvil, and the stirrup, also called the malleus, the incus, and the stapes, which are the proper names for them. And they're connected together by little joints. And so what happens is noise comes in here, it vibrates the eardrum, these 3 bones vibrate, and then it goes into the inner ear here, which is the cochlea. The cochlea is this seashell type structure. It's also connected to these gyroscope type structures here, which control your balance. So the inner ear is concerned with hearing and balance at the same time. This nerve here goes from the cochlea and the balance system and goes off to your brain. That's called the vestibular cochlear nerve, one of the cranial nerves in our head. So these are the structures that we must think about when we think about what may go wrong with your ears. So what symptoms may your ear problems give you? Well, the 3 main things that people describe are an alteration in their hearing, usually hearing loss, obviously. Their hearing is not as good as it has been. You may get tinnitus, and the diagnosis, that tinnitus means noises in the ears with no external source, and that can be any noise you hear. It can be a buzzing, a ringing, a whooshing, any noise that you experience is actually tinnitus. The definition, noises in the ears with no external source. So people may hear these noises. You may get balance problems, and obviously that may be due to the inner ear, not always, because there's lots of things that can cause problems with your balance. But one of the things that can is your inner ear, as I've described. Those gyroscopes, which are in your inner ear, can get problems, and you may get dizziness. And then the more acute type symptoms that you may describe, particularly if you have infections either in your outer ear or your middle ear, are pain and discharge. So the more chronic type long-term symptoms are hearing loss, tinnitus, and balance problems, and the more acute infective type issues, pain and discharge. So these are the things you may get with problems with your ears. So when we think about how we're going to treat these things, we obviously have to think what the cause is. So problems in the outer ear, what may be your experience with that? Well, you may get some wax, and this is very common now, particularly as people can't access, unfortunately, wax clearance services in primary care. We're seeing a lot of patients now who are getting wax impacted in their ears and also getting infections in relation to that, because when you get impacted wax, it often gets infected. You may get what we term infection in the outer ear, or otitis externa, and this is very, very painful. This is a really sore condition with discharge, and your ear may well swell up and so therefore give you hearing loss as well. If you're unlucky or a little careless, you may get a foreign body stuck in your ear. And as adults, we often see people with hearing aid molds that have snapped off or come off, or if you're trying to remove your wax with a cotton bud, which is probably not the best thing to do, you may get your cotton bud stuck in your ear, and these are things we often fish out. There's all sorts of things we also fish out in children, but we won't go to that today. Problems in the middle ear are often related to that problem with that tube I mentioned at the back of your nose, the eustachian tube, which may, for some reason, not work as well as it should. And we term this eustachian tube dysfunction. This has been traditionally a condition that's been very difficult to treat, actually. But we have this new treatment now called balloon eustachian tuboplasty, which is a quite exciting new development. And I'll show you a little video of that in a minute, to actually help that along, and really has beneficial results for people with this condition, which is very irritating, giving you a feeling of muffled hearing and sometimes popping and cracking in your ears, which a bit like you get when you've had a cold and before it sort of gets better. If that gets worse, and I've mentioned in children, it can happen more commonly in adults, but it also happens in adults, you may get actually fluid behind the eardrum in that middle ear, so-called glue ear. And this is effectively just mucus in the middle ear that can't get out because the eustachian tube, that only way out of the middle ear is via the eustachian tube. If that's not working, the mucus just gets stuck. And so you get glue ear. And again, this gives you a very muffled sensation with your hearing and can be very irritating. If that's the case, you may need the insertion of a grommet. And I'll show you a little video on that in a second, which is a very simple and easy way to clear this up. Occasionally, very unusually, you may get disruption of those little bones of hearing, those 3 little bones of hearing I described earlier. That may give you a hearing loss, but more seriously, you may get something called a cholesteatoma, which is a very deep-seated and progressive infection in your middle ear, which can lead to some quite severe consequences and really bad side effects. So if you have certainly have a smelly, nasty discharge that's not getting better, it's really worth seeing someone sooner rather than later to exclude a cholesteatoma, which, if it's there, does need quite extensive surgery to treat. Lastly, of course, problems in the inner ear, and this is more related to hearing loss and tinnitus. Clearly, the cochlea is your main sort of sensory organ as far as hearing is concerned, and if you get, for some reason, problems in there, you may well get some hearing loss and tinnitus in particular, but also balance problems as well. The issues that we see most of generally are age-related hearing loss. Unfortunately, we all lose our higher frequency hearing as we get older, and this is termed presbyacusis. And once diagnosed by a hearing test, which we can obviously do for you here at Benenden, we can offer you, or we can suggest you get some hearing aids for that. We don't actually offer hearing aids here, but it's certainly something that we can recommend for you elsewhere. Meniere's disease is a disease where basically you have too much fluid in your inner ear, in that cochlea I described to you earlier, and that gives you the classic triad of symptoms, as I said earlier: the hearing loss, the tinnitus, and the vertigo or the dizziness. That's a condition that I won't go into more detail here, but again, would be something that we can diagnose for you here at Benenden by examining you and performing a hearing test. Lastly, acoustic neuroma. This is a benign tumor on the hearing nerve. So that hearing nerve that goes from your inner ear into the brain can get a benign tumor of the Schwann cells, which are the cells which surround that nerve. And that leads to often a one-sided inner ear nerve type hearing loss, and also potentially one-sided tinnitus, which is unusual. Tinnitus is usually both sides if you're going to get it. So one-sided tinnitus is something to be aware of, and hearing loss. So if you get one-sided hearing loss, one-sided tinnitus, and some dizziness, we would certainly perform what's called an MRI scan of your inner ear and your balance and hearing nerve and your brain to check that you haven't got one of these vestibular schwannomas. And we do pick them up every now and again. I mean, from the people that we see with those one-sided symptoms, about 1 in 1,000 will have a vestibular schwannoma. So it's very unusual, but we do pick them up from now and again, and we do an MRI scan to put your mind at rest in any case. So in the clinic, what do we do? Well, we can do microscopy of the ear, here and now. So, you know, we sit you down, we have a microscope in the clinic, we can look in your ear, we can clean out any debris, we can clean out any infection, we can look at your eardrum. So here is another patient having that exact procedure, very quick and easy. The little thing I'm holding in my right hand there is a tiny little Hoover device. So it's called microsuction, using the microscope. We can also, as I've mentioned, perform an audiogram. So we have a dedicated, very skilled audiometrist here who can perform a hearing test for you while you wait. And then you have the combination of my consultation and also a hearing test here and now, which I can tell you the result of straight away. So this is a sort of setup that we would do for someone with ear problems in the clinic when we see them. This is a grommet. So for someone who has glue ear, this is a little video of a grommet. So that's your eardrum. If you put it in perspective, that's smaller than your little fingernail. So we're looking down a microscope, down a little speculum there. We're going to make a little cut in the eardrum with a tiny little knife called a moringatome. So we make a little cut in an appropriate area of your eardrum there, tiny little cut in the eardrum, about 1 or 2 millimeters long. And in the middle ear there, sometimes glue ear or the mucus will flood out. In this case, it hasn't. But if I put a little microsuction device, much as I showed you on the last slide, into the ear, I can then remove the mucus or the glue from your middle ear. So there's me suctioning noise into your middle ear to get the mucus out. And there you can see the sort of yellow mucus in the middle ear there as it comes out. So we make the hole and we actually remove the mucus at that same time. Then we put in the grommet, which is this tiny little drainage tube. Basically, looks like a tiny little cotton reel with a little hole down the middle. So we place that carefully into the hole that we've done, gently position it. There's a little flange on it that stops it coming out. So with a little needle, we pop the grommet in the right position. So this is a procedure that sometimes we can do under local anesthetic. So we put some cream in your ear for half an hour to an hour to numb it up if you're quite stoical, and we can do that. Otherwise, we most of the time would do it under a general anesthetic, but it is possible to do that under local anesthetic if possible. So there's the grommet in position. You can see the hole down the middle, which allows the middle ear to ventilate and stops the fluid from reaccumulating inside the ear. So that is a grommet. Balloon eustachian tuboplasty is the operation I mentioned earlier. This is for people with not full-blown sort of glue ear, but with eustachian tube dysfunction. So the eustachian tube, for some reason, is not working properly. So we put a little balloon into that eustachian tube that I showed you earlier, into the opening, and blow it up. And what that does is inflate it, I should say, rather than blowing it up, to stretch the eustachian tube up to allow it to work better. So here is a balloon eustachian tuboplasty. Going into the nose, much the same before. This is a little introducer, this little gentle blunt-ended introducer that we put towards the back of the nose under endoscopic guidance, operating off a television screen. So we put the little introducer into the eustachian tube opening at the back there, gently put that into there, and then push the balloon over the top of that into the eustachian tube and blow it up. And you'll see the air going in a minute. So there is the balloon in place in the eustachian tube. We then wait for 2 minutes. We deflate it. for a minute, and then we inflate it again for another minute. So that's 3 minutes of inflation. Then here's the balloon in situ. We deflate the balloon and we remove it. So again, that's pretty much in real time. It's a very quick and easy maneuver, and you'll see there's the nicely opened eustachian tube there, with a nice big hole basically for the eustachian tube to drain through into your middle ear, and that's successful in a good number of patients to improve their eustachian tube dysfunction. Previously, we had very little that we could do for this condition, so it's quite exciting, this new balloon technology. So just in summary, what is the Benenden Hospital's ENT ethos? Well, as I would like to emphasize more than anything else, it's prompt and accurate diagnosis. It's so important to not let your ENT problems, fester, as it were, for months and years on end. As I see so commonly, unfortunately, now in these days, it really is very common that people don't get swift and accurate diagnosis, which is disheartening, but that's just the way it is at the moment, I'm afraid. A one-stop ethos of diagnosis and instigation of a treatment plan. We try to see you, and as I've said, we do a hearing test. Sometimes we need to do a CT scan, but that's often just to confirm the diagnosis rather than to make it. The diagnosis is usually made after your visit, once we've examined your nose and done various tests and things. So very much a one-stop ethos. A bespoke treatment plan, towards your particular symptoms. It's a great raison d'etre of mine to give people for their noses really good sort of plans, not just for the immediate future, but also for the medium and long term, to keep your nasal problems under control. Even if you do require surgery, that would be something that I'd be keen to give you moving forwards. There are a wide range of day case surgical solutions, as I've sort of outlined here. Should your medical problems or medical treatments that I offer you not be effective. And the underlying sort of ethos really for all my patients is early return to work and normal activities. We don't like to have people off work for long periods of time. And most of my patients will say how the surgery and the treatment we've done has made their quality of life so much better, that their sleep is better, their work is better, their personal relationships are better, which is a great sort of thing to hear. So I hope you found that helpful. If you'd like to ask any questions, I'm sure we'd be pleased to hear them. Thank you very much.
Thank you. That was really fascinating, really interesting, especially the videos. It was amazing seeing it in action. So thank you.
I hope they weren't too gruesome.
I don't think so. Okay, hopefully for some. So we have a few questions and I'll just go through them. So the first one is, they have inflamed sinuses and their doctor prescribed them with a steroid nasal spray, but they still suffer with headaches and head pressure. What should they do?
Well, I'm afraid I'm going to say you should come and see me. Yeah, that's a very reasonable thing for your GP to have given you early on. A nasal spray, a steroid nasal spray is designed to reduce the inflammation inside your nose. So hopefully is to open the sinuses up and allow the sinuses to drain easier. If it doesn't work, then basically the thing you need to do is to have someone look in your nose with one of those endoscopes, which I showed earlier, and potentially you need a CT scan of your sinuses. So I think you would fit in very much into that category of patients that have tried medical treatment. The one thing I would do if I saw you was possibly to give you some stronger medical treatment before anything else. So I would normally move up to something like a nasal drops, which are a slightly stronger steroid preparation than the nasal spray. But I think in general, if the nasal spray has not worked, then you need to possibly go and see myself or a colleague, an ENT colleague, to have a look in your nose with the endoscope.
Yeah, okay, thank you. The next two are around earwax. First is, what are your thoughts on ear candling?
No.
That's nice and clear.
There is no evidence of ear candling help. People ask me this, and I just fear for ear candling because you can set your hair on fire, you can do all sorts of things. I really wouldn't recommend ear candling. I mean, syringing is fine, and it doesn't work for some people because the water inside your ear can cause a little bit of irritation and infection. The best treatment is microsuction, and I would say that, of course. But the point is, with microsuction, you are looking in the ear, you are seeing exactly what you're doing, And the other thing is you're removing absolutely every scrap of wax, because I won't stop until I've got every little bit out. Ear candling is relying on sort of a little bit of sort of pressure changes in the outer ear, pulling the wax out of your ear. The thing is, wax varies very much in consistency. So I would imagine maybe ear candling and syringing, for that matter, works for people with very dry wax, which comes out fairly easily. But if people, as they often do, have tried olive oil and this, that, and the other, and it creates a sort of sloppy wax inside your ear, and that's not going to come out with candling, I'm afraid. It's not going to come out really with syringing either. It needs to be suctioned out with microsuction. So my advice, and I know I'm a traditionalist, and whatever, is not to do candling, to be honest. I wouldn't recommend that.
Okay, thank you. The next participant says they wear a hearing aid which causes their ears to create more wax and can cause a blocked ear. What would you advise they do?
Well, I'm afraid that's the same thing, really. You need to have people who wear hearing aids, and also, unfortunately, it's a bit of a self-fulfilling prophecy. If you've had your ears cleaned out before, it tends to make the wax form a bit more regularly. So in general, if you wear a hearing aid, it will stop the natural migration of wax out of your ears, because wax is very clever, or the ear canal is very clever. The skin migrates out of your ear. So if you put an ink dot, a non-absorbable ink dot in the middle of your eardrum, 6 weeks later, that dot will be visible on the outside of your ear, because the skin migrates outwards. So the wax is, as the skin migrates outwards, the wax is pushed outwards as well. So unfortunately, if you wear a hearing aid, that sort of skin function is slightly, is not functioning quite as well as it should. So the wax can get stuck a little bit. So I think, to be honest, you will need to have some sort of help to get the wax out, either by syringing from your GP or possibly microsuction. I mean, for instance, there are, certainly I work in East Kent hospitals in the NHS, and there are a number of my clinic nurse specialists that do it in the NHS. There are also GP practices that do it in East Kent around here. But of course, there is the option to come here to Benenden to have that carried out by one of me or one of my consultant colleagues, which will give you the peace of mind of getting absolute complete clearance of your wax. So I think hearing aids, probably you will need to have wax clearance every now and again, possibly every year.
Okay, thank you. I have two questions relating to dizziness now. So first participant says they experience bouts of dizziness. Is it still safe for them to drive?
Well, that's a very good question. It depends on your balance, what particular, how your balance problems presents itself. So the DVLA, and if you are concerned, you should check on the DVLA website, because there is some sort of bits and pieces on that. In general, the guidance is, however, if you have, obviously, if you're dizzy all the time, then you shouldn't drive. But if you have the occasional bout of dizziness and you get no warning, so in other words, you can be driving along and suddenly you get hit by this bout of dizziness, then you shouldn't drive. So no warning for your dizziness, you shouldn't drive. However, if you do get warning and you can sort of pull over and stop and then sort of take stock of yourself and whatever, then that's usually okay. But if you're in any doubt, you ought to talk to the DVLA, because of course the other issue, of course, is whether your car insurance will cover you if you're known to have dizziness. So it's something to be aware of. But in general, if you look on the DVLA website, it's if you get a warning or if you don't get a warning.
Okay. Another one relating to dizziness is what could be possible to help one-sided tetanus plus dizziness when tilting head back?
Well, as I say, if you've got one-sided dizziness, you probably ought to come and see someone about it, because that's a one-sided tinnitus and dizziness, very rarely can be a sign of an acoustic neuroma or a vestibular schwannoma. So we really ought to come and, again, see us here or access your local services to have a hearing test and potentially have an MRI scan, just to just to be sure there's nothing else going on there. So in ENT in general, actually, one-sided symptoms, you've got two nostrils, two ears, is one-sided symptoms are more worrying than both-sided symptoms. Although I think it's probably very unlikely that you do have it to worry about, but one-sided symptoms is definitely something worth consulting someone about.
Okay, thank you. Okay, I have a question from Sarah. She says she has had a croaky cough and throat for the past year. She also suffers with a stuffy nose, catarrh, and post-nasal drip. She has always had problems with catarrh, but has become more constant. She also gets sinus bother and experiences forehead pain. She uses Dymista, is it? Dymista, yep, which helps a bit.
Yeah.
And a more recent problem is a dry mouth, but it may be due to high blood medicines. Could could an underactive thyroid cause the throat problem? And would it be better to get it all investigated?
That's a lot to, blimey, that's a lot to,
Yes.
yeah, I think that the issues with your nose, I think probably needs some stronger medication. So the blocked nose, the catarrh, things like that, that Dymista is not going to be enough for that by the sounds of it. You probably need at the very least some stronger nasal steroids, and I was mentioning earlier, some nasal drops for a period of 6 to 8 weeks, something of that nature, to try and clear the nose out a little bit. That nasal problem will be causing you probably a dry mouth, because you can't breathe very well through your nose. So you will tend to get a dry mouth and problems of that nature. So that knock-on effect will probably be quite understandable. So I think in general, what I would say to you is to come and see someone. I mean, that, just as I described earlier, those are the sorts of symptoms that we see all the time. And if you've been trying medicines from your GP which haven't worked, then the next stage is secondary care with us, basically. And we can examine your nose with the endoscope. We may want to do a CT scan, because if you've got a lot of infection and inflammation in your sinuses, you may need surgery. And I think if it's going on a year, that may well be the case. I think that, as I say, the throat problems, the croaky voice, may well be related to the fact that your nasal problems, you've got postnasal drip, which is irritating your throat. You can't breathe very well through your nose, so that's causing a dry mouth. So it all would add up. The one thing I would say, an underactive thyroid can give you voice problems. So if you haven't had your thyroid function tested, or you know yourself to be underactive thyroid, yes, hypothyroidism can cause voice problems. So worth getting that checked as well. But it sounds as though you do need to come see someone.
Yeah. Yeah. Okay. Thank you. Just a few more questions. One participant says, how does progressive submucosal fibrosis affect ears in a patient?
Progressive submucous cell
Fibrosis?
fibrosis. I'm going to have to plead ignorance there. I'm sorry, I don't know that condition.
Saying it wrong. Mucosal. No.
I don't know that condition, I have to admit to you. But I'm very happy to look it up if you want to write to me. But I can't specifically comment on that condition because I don't know of it.
Okay. Another participant says they have eczema and sometimes has itchy, runny, blocked ears. Over the years, various GPs have said put oil in, but this just makes them more blocked. Can you suggest alternatives, please?
Yeah, and that's what I mean. I mean, unfortunately, people's problems in their ears is not all, the same. Wax is not the same, and the skin problems are not the same. I mean, we do see a lot of patients with eczema and psoriasis who get problems, general skin problems, who have problems in their outer ears. So one thing I would say is keep your ears scrupulously dry. If you've got dry skin around the ear, you mustn't get water in your ears, because the natural barrier to infection is not, of your skin is not as good as it should be. In general, I wouldn't advise using oil and stuff. What I would advise is you can use some steroid ear drops, because steroids, much the same as you would use for your eczema, as a liquid form inside your ears, is good for the skin. But again, occasionally, I'm afraid, in your case in particular, syringing is not going to be any good. You may need to have your ears cleaned out. Microsuction is the best way, because that's the most gentle way. It's the way that will, get all the debris out of your ear under direct vision. So we'll see, everyone will know exactly what we're doing. So I think every now and again, if you do have these conditions, you will need to have your ears microsuctioned. It's the access problem that I know will be a problem to you, but that's what I'd recommend, as well as keeping your ears scrupulously dry and steroid drops.
Okay, thank you. Julia said she's sadly already had nasal polyps and a deviated septum, both of which were resolved under surgery some years ago. She's also needed a grommet in the past. But now she finds postnasal drip is bad, and constant throat clearing, constant blowing of the nose, and low-level tightness in the ear. She suspects the polyps may have returned. She uses Dymista and cetrizine daily with Flixonase droplets when it gets very bad. Should she come and see you? And if so, how does she need to get a GP referral to do so?
Well, the thing to say about that is that's not too uncommon. If you have nasal polyps, as I mentioned earlier, you've often got an underlying inflammatory tendency, be it asthma or whatever, and that's the same. In your nose, the nasal lining will not change after surgery. So the old adage used to be, if you get nasal polyps, no point having surgery because they always come back. Well, that's not true, actually. If you do the surgery very carefully and you remove all the polyps, then you will have a much less chance of having your polyp back. But you will need to use, as you've said, long-term intranasal steroids by ways of sprays or drops. And some GPs are reluctant to prescribe these sprays, but the newer generation ones are very safe to use long-term. So you're not unusual in that you're experiencing some stuffiness in your nose after surgery. If the symptoms are still there despite the fact you're using intranasal steroid sprays, then probably someone ought to look up your nose to make sure your polyps aren't back. By the sounds of things, there may be a little bit of inflammation inside there. You may need a little bit more tidying up surgery, or you may need something slightly stronger by means of steroids, by a short course of oral steroids, or as I say, some drops are slightly stronger than the spray. So I think on balance, you probably should go and see someone and let them have a look up your nose to see what the state of play is as much as anything. The other thing that can be quite helpful, which I haven't mentioned before actually, for mucus and things, is saltwater douching or sinus rinse. So there is a kit that you can buy called Sinus Rinse. The other one that people use is an aerosol spray called Sterimar, which is salt water essentially at the right concentration. And to flush out your nose every now and again with this stuff is very helpful. It keeps the mucus blanket healthy and makes your nose feel nice and clean. And I'd give it to everybody after surgery. But if you've had issues inside your nose on a daily basis, flushing it out with salt water, Sinus Rinse, made by a company called NeilMed. I don't get commission on that, but it's a very good device. A little squeezy bottle like a fairy liquid bottle and sachets of powder, very easy to use, and it makes the nose feel nice and clean. So you might find that helpful as well from the mucus point of view.
Thank you. Just last two questions, we're running out of time. Peter said he woke up with ringing in his ears about 3 months ago. He's had a steroid nasal spray treatment, which made it slightly better. The ringing comes and goes. He believes it's somatic, caused by neck issues. He's had 2 MRIs booked for the near future for spine and neck abandon. Would this pick up anything to help with the tinnitus?
Well, what you also probably should have is a hearing test, to be honest, if you haven't had a hearing test. So I'm not sure if you've seen one of us or which department you've come through, but if you have tinnitus, one of the first things we do is probably just to do a hearing test to see that whether you've got any hearing loss associated with it or whether your hearing's normal. Tinnitus is very common. I mean, I could talk to you for an hour on tinnitus. I don't think you'd want me to, but it's very, very common. And there are lots and lots of different causes of it. To be honest, most of the time, we don't really find a cause. I mean, there's a list as long as your arm. And when I was a trainee ENT surgeon, one of the things you learned before an exam was causes of tinnitus, about 5 pages long. But most of the time, you don't find a cause, and it's just treating the symptoms. I think if you're wanting advice on tinnitus, there's a very good website, the British Tinnitus Association, which is www.tinnitus.org.uk, and that will give you very good bits and pieces of advice on tinnitus. But generally, if you're concerned about it, and I said before, particularly if it's one-sided, then you ought to come and see someone. But it's worth reading about the tinnitus on the British Tinnitus Association and educating yourself, actually, in the first instance, I would say.
Great, thank you. Okay, last question is, hopefully I got this word right, is Avamys, is that right? Safe to use?
Avamys, yeah.
Avamys, is it safe to use in the long term?
Yeah, absolutely. Avamys is fluticasone, which is a nasal steroid which we've been using for a long time. It's one of the newer generation of steroids, which, you can use long term. It's usually 1 puff in each nostril once a day. And that's one of the ones I tend to give for my patients who've had nasal polyps surgery to try and prevent recurrence and to keep things under control. So yeah, that's a safe one.
Okay, great. Okay, well, that's all our questions. So thank you everyone for sending in your questions and participating. And thank you very much. It's been really interesting. If we haven't answered all your questions, I've seen that just come up, we will do so after this event. So please do send them in still, and we will send you answers. There's a number on the screen which you can book a consultation on. Paul Farrow is there till 8 p.m. this evening if you want to call up and book. Otherwise, our friendly private patient team are there 9 till 5, Monday to Friday. After this webinar ends, you'll receive a short survey, and we'd really appreciate it if you could fill that in. It won't take more than a couple of minutes. It just helps improve these webinars for future sessions. Our next webinar is a very different subject. It's on weight loss surgery. It's on the 26th of January. It's with Mr. Ahmed Hamouda, consultant surgeon, and Maria Duckworth. So if you would like to book into that, please do so via our website. So thank you very much, Henry Sharp, for your presentation. It's been really interesting.
Thanks very much. Thank you for joining us.
Yeah, thank you everyone else for joining us, and on behalf of the hospital and the team, say thank you, and we'll see you all soon, and have a good evening and Christmas. Okay, thank you. Bye.
Bye.